Welcome back to the deep dive. Today we are tackling something really fundamental and honestly pretty scary in medicine. Altered mental status, or AMS.
Yeah, it's a big one.
If you've ever seen someone suddenly get confused or maybe unresponsive, just completely not themselves, you know how worrying that can be.
Absolutely. And altered mental status is really a catch-all term. It means any significant change in how someone's thinking, their level of consciousness, their behavior, even their mood.
Right, it's a huge spectrum.
It is. It could be mild confusion, maybe they're just a bit foggy, a little off, or it could be, a rapid slide into a full coma where they're not responding at all.
And the way it happens can vary so much too, right? Like it could be super sudden.
Exactly, like acute intoxication maybe.
Mm.
Or it could be this slow, gradual decline over days or weeks, something like you might see with, say, advanced liver disease developing hepatic encephalopathy.
The key thing, though, is that it's always a symptom, yeah? It's never the actual diagnosis itself.
That's the absolute core challenge here. So our mission in this deep dive is to really walk you through the systematic approach, the framework that clinicians use to try and quickly figure out why someone has AMS.
Because the underlying cause could be anything.
Literally anything from, low blood sugar, which is often easily fixed, to something life-threatening like bleeding in the brain or a severe infection. It really demands structured thinking, often under intense time pressure.
Okay, let's break down that structured thinking. Starting right at the beginning, patient comes in, clearly altered. What are the absolute first steps, the non-negotiables?
Right. So stabilization first, always. We use the ABCDE approach. That's airway, breathing, circulation, disability, and exposure.
The basics.
The absolute basics. Because if the patient can't maintain their airway, if they're not breathing effectively or their circulation is failing, well, nothing else matters until those are sorted.
Okay, so assuming A, B, and C are stable or being managed, we get to D for disability. And that brings us straight to the Glasgow Coma Scale, the GCS.
Exactly. The GCS is so important because it gives us an objective score. It's a number based on very specific criteria: their eye-opening response, their verbal response, and their motor response.
Then the scale runs from?
It runs from 3, which is basically completely unresponsive, deep coma, all the way up to 15, which is fully awake, alert, and oriented, normal.
Now, I think there's a really critical number here that everyone listening should probably know. That GCS score of 8 or less, why is that such a red flag?
Yeah, that's a crucial threshold. A GCS of 8 or less generally indicates that the patient is so significantly impaired, so obtunded, that they likely can't protect their own airway anymore.
Meaning they could aspirate.
Precisely. They could aspirate stomach contents into their lungs, and that can be catastrophic, even fatal. So a GCS of 8 is kind of the widely accepted benchmark when you strongly consider or often proceed with immediate intubation to secure that airway.
Wow, okay. That definitely puts it into perspective. So beyond assessing the GCS, what are the sort of immediate practical interventions we need to be doing right away?
Okay, so 3 key things, almost simultaneously. 1, get IV access established. 2, immediately check a finger stick blood glucose level right at the bedside.
Because low blood sugar is common and fixable.
Exactly. And if that glucose comes back low, say under 55 or 70 milligrams per deciliter, depending on the guideline, you give IV glucose immediately, brain cells need glucose.
And the third thing?
The third is often giving naloxone, the opioid reversal agent, especially if there's any suspicion at all of an opioid overdose causing the AMS. So you're kind of covering those immediate reversible threats: airway, glucose, opioids right up front. And of course, continuous vital sign monitoring is essential throughout.
Right. And this immediately highlights a huge challenge with AMS, doesn't it? The patient often can't tell you anything.
Exactly. They're frequently a poor historian or maybe no historian at all in that acute phase. So getting the history becomes detective work, talking to family, caregivers, emergency responders, witnesses, anyone who saw what happened.
What kind of clues are you looking for?
You're trying to piece together the timeline. Was it sudden, gradual? Were they confused and fluctuating, which might suggest delirium? Or did they just acutely drop their level of consciousness, maybe pointing towards a stroke or trauma? The physical exam then helps confirm things like the decreased level of consciousness, any confusion, memory issues.
Okay, so we've stabilized. We've checked the glucose. Maybe it was low and we fixed it. Maybe it was normal. Now we start digging deeper diagnostically. And we have to circle back to glucose again because of those major diabetic emergencies, right?
Yes, absolutely. Even if the initial finger stick wasn't low, it could be dangerously high. We need to consider diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic syndrome, HHS.
Two very different beasts, even though both involve high blood sugar.
Very different. Both are serious diabetic crises, but the underlying pathophysiology, and therefore the lab picture and the treatment, are quite distinct.
Let's try and pin down those differences. DKA, sometimes described as the body sort of burning fat frantically because it can't use sugar.
That's a good way to put it. In DKA, there's a profound lack of insulin. The body can't get glucose into the cells for energy, so it switches to breaking down fat. The byproduct of that rapid fat metabolism is ketones, which are acidic.
Ah, hence the ketoacidosis.
Exactly. So in the lab results for DKA, you'll see high glucose, usually over 250 milli-GDL.
Yeah.
But the defining features are the signs of severe acidosis. A low blood pH, typically below 7.3, and a low serum bicarbonate level, usually under 15. Plus, you'll find high levels of ketones in the blood and urine. That confirms the acid production.
Okay, so DKA is mainly about the acid buildup. How does HHS differ?
HHS is primarily a state of extreme dehydration and hyperosmolarity. The glucose levels in HHS are often incredibly high, frequently way over 600 milli-GDL, sometimes even over 1,000.
Whoa.
Yeah, but the key difference is that in HHS, there's usually just enough insulin present to prevent the body from switching over into that massive ketone production state. So they don't develop the severe acidosis like in DK.
So their pH should be relatively normal, minimal ketones.
Generally, yes. The pH is usually above 7.3, bicarbonate above 18, and ketones are minimal or absent. What makes HHS so dangerous, and often causes profound AMS, is the extremely high serum osmolality, usually over 320 meos/mkh.
Meaning the blood is super concentrated.
Exactly. It's so concentrated that it literally pulls water out of the body's cells, including brain cells, trying to dilute the blood. So the patient becomes severely dehydrated at a cellular level. Understanding these lab differences is critical because DKA treatment focuses heavily on stopping the acid production and correcting the acidosis, while HHS requires massive amounts of intravenous fluids to rehydrate the patient and slowly, carefully lower that osmolality.
Really important distinction. Okay, so glucose is sorted, high or low. What's next on the checklist?
Yeah.
Respiratory issues seem logical.
Absolutely. After glucose, you must rule out problems with oxygenation or ventilation. So hypoxia, low oxygen, or hypercapnia, high carbon dioxide.
How do those present?
Well, the patient might be visibly short of breath, have an abnormal respiratory rate too fast or too slow. Maybe they look bluish, cyanotic, or you hear abnormal lung sounds on exam.
And you'd confirm this with an ABG, arterial blood gas.
Correct. The ABG gives you the definitive numbers. Low partial pressure of oxygen, PO2, confirms hypoxia. Elevated partial pressure of carbon dioxide, PaNO2, confirms hypercapnia, which usually means the patient isn't breathing adequately to blow off CO2. That buildup of CO2 makes the blood acidic and can definitely cause AMS.
Got it. Okay, moving on from internal gas exchange problems to external factors, toxins and medications. This seems like a huge area.
It is, and the physical exam can give you some quick clues here, especially with intoxication. There are often contrasting signs depending on the substance type.
Like stimulants versus depressants?
Exactly. If someone's taken CNS stimulants, think amphetamines, cocaine, you might see signs of overdrive. Sweating, rapid breathing, maybe agitation, and characteristically dilated pupils.
And the opposite for depressants.
Right. For CNS depressants, opioids are the classic example, but also benzodiazepines. Alcohol, you look for suppression. A decreased respiratory rate, which can be dangerously slow, sedation, and often constricted, pinpoint pupils, especially with opioids.
And then you'd confirm with, say, a urine toxicology screen and a serum alcohol level.
Yes. Those tests help confirm suspicions. But we also need to think about withdrawal, which can be trickier than acute intoxication.
How so?
Well, withdrawal implies a history of regular use followed by recent stopping or cutting back significantly. And the symptoms vary wildly depending on the substance. Alcohol or sedative withdrawal can cause extreme agitation, high heart rate, high blood pressure, even seizures. Stimulant withdrawal, on the other hand, often looks like profound depression, fatigue, increased sleep.
And there's a really important point about alcohol withdrawal, isn't there? It can happen even if they still have alcohol in their system.
Yes, this is a critical clinical pearl and a very high-risk situation. For someone who is a chronic, heavy alcohol user, their body adapts to the constant presence of alcohol. They can actually start going into severe withdrawal, like delirium tremens, with hallucinations, confusion, autonomic instability, even while their blood alcohol level is still detectable, maybe even legally intoxicated.
Because their normal requires that high level.
Essentially, yes. Their baseline physiology depends on the alcohol. So even a relative drop, even if still positive, can trigger a dangerous withdrawal cascade. It's something you always have to be vigilant for in heavy drinkers presenting with AMS.
Okay, that's crucial. What about prescribed medications causing AMS? How do you spot that?
It's mostly about the history and timing. You're looking for a temporal link. Did the altered mental status start shortly after a new medication was started or after a dose was increased? Particularly medications known to have CNS side effects, things like certain antiepileptics, antipsychotics, sedatives, even some blood pressure meds or antibiotics in vulnerable patients. If the timing fits, the medication becomes a prime suspect.
Makes sense. Okay, let's pivot now inwards to the brain and central nervous system itself. What are the big hitters here? Starting with trauma.
Traumatic brain injury, TBI. Obviously, you need a history of some kind of head trauma, blunt force usually. On exam, you might find focal neurological deficits like weakness just on one side of the body, what we call hemiparesis.
And diagnosis relies on imaging.
Absolutely. You need a head CT scan urgently to look for evidence of injury like intracranial hemorrhage, bleeding inside the skull, or cerebral edema, which is swelling, or bruising of the brain tissue, a contusion.
Okay. Next big CNS category, stroke or cerebrovascular accident, CVA.
Right. Strokes are typically characterized by a sudden onset of neurological symptoms. It could be trouble speaking or finding words, facial droop, weakness, or just sudden obtundation that state between lethargy and stupor.
And risk factors help point toward stroke.
Definitely. A history of high blood pressure, smoking, diabetes, atrial fibrillation, those increase the suspicion. Again, the head CT is critical to diagnose it and determine if it's ischemic, caused by a clot-blocking blood flow, or hemorrhagic, caused by bleeding.
And the third major CNS group is infection inside the head, meningitis or encephalitis. What are the classic warning signs?
The classic triad, though not always present, is fever, headache, and photophobia, which is a severe sensitivity to light. You might also find neck stiffness, what we call neutral rigidity, where it's painful or impossible to touch the chin to the chest.
And diagnosis isn't from a CT here.
Not primarily for the infection itself, though CT might be done first to rule out other things. The definitive diagnosis requires a lumbar puncture, a spinal tap, to collect cerebrospinal fluid, the fluid surrounding the brain and spinal cord. Analyzing that CSF is how you identify the infection.
Okay, so we've covered direct CNS issues, but sometimes the infection causing AMS isn't in the brain at all, right? This is a really important point, especially for certain patient groups.
Hugely important. And it's often the less traumatic infections that are the most common culprits, particularly in elderly patients. We're talking about urinary tract infections, UTIs, and pneumonia.
It seems surprising that a UTI could cause such profound confusion.
It does, but it's incredibly common. An older adult might develop significant acute confusion or delirium from a UTI without reporting any of the classic symptoms like burning with urination or urinary frequency. The infection triggers a systemic inflammatory response that affects the brain.
So if they can't report symptoms, how do you track it down?
You often rely on the urinalysis. You look for suggestive signs reported by caregivers like new incontinence or agitation of just unexplained AMS. The urinalysis will typically show markers of infection like nitrates, leukocyte esterase, white blood cells, or bacteria.
And pneumonia, similar story.
Similar in that it's a common systemic infection causing AMS, especially in the elderly or frail. With pneumonia, you might see more typical signs like fever, maybe a productive cough, possibly low oxygen saturation. Listening to the lungs might reveal crackles, and the diagnosis is usually confirmed with a chest X-ray showing infiltrates, which indicate infection in the lung tissue.
Right. Okay, we're nearing the end of the common causes. Let's talk about when major organs fail and the waste products back up, causing encephalopathy. Starting with the kidneys, uremic encephalopathy.
This occurs in patients with severe kidney disease, either acute or chronic. When the kidneys aren't filtering waste products effectively, things like urea build up in the blood to toxic levels.
What does that look like clinically?
Symptoms often include confusion, lethargy, sometimes muscle cramps or itching. And there's a characteristic physical sign we look for called asterixis.
Asterixis. Can you describe that? What does it look like?
Sure. It's sometimes called a flapping tremor. You ask the patient to hold their arms out straight in front of them with their wrists extended back like they're stopping traffic. Someone with asterixis won't be able to maintain that posture steadily. Their hands will intermittently, involuntarily flap forward and then return.
Huh. And that's caused by the toxins.
It's thought to be a direct effect of the metabolic disturbance, the uremic toxins, on brain function, particularly motor control pathways. Diagnosis is supported by lab tests showing very high levels of BUN, blood urea nitrogen, and creatinine, indicating poor kidney function. You might also see electrolyte issues like high potassium.
Okay, so if kidney failure causes uremic encephalopathy, liver failure leads to hepatic encephalopathy.
Exactly. This is seen in patients with significant liver disease, usually cirrhosis. The damaged liver can't effectively detoxify the blood coming from the gut. One key toxin that builds up is ammonia.
And ammonia is bad for the brain.
Very bad. It crosses the blood-brain barrier and interferes with neurotransmitter function. Clinically, besides the AMS, you might see physical signs of liver disease like jaundice, yellow skin eyes, ascites, fluid buildup in the abdomen, maybe pulmonary erythema, red palms. And interestingly, asterixis can also be present in hepatic encephalopathy.
So that flapping tremor isn't specific just to kidney failure.
No, it's seen in several metabolic encephalopathies, liver failure being another major one. Often, the combination of known cirrhosis plus finding asterixis is highly suggestive of hepatic encephalopathy. Lab tests showing elevated liver enzymes, AST, ALT, ALP, and bilirubin, support the diagnosis of liver dysfunction. Measuring ammonia levels can also be helpful, though they don't always perfectly correlate with the severity.
We've covered a lot of ground. Are there other, maybe less common metabolic or systemic causes we should keep in the back of our minds, the sort of final sweep?
Oh, definitely. It's a broad differential. You always have to consider significant electrolyte abnormalities like severely low or high sodium, hypernatremia, or calcium issues, hypercalcemia. Major acid-base disturbances beyond DKA can do it too.
Then other systems.
Yes, endocrine disorders like severe thyroid failure leading to myxedema coma. Then there are structural things like brain tumors, though often presenting more gradually. Severe psychiatric conditions can sometimes manifest as altered mental status. And one more subtle but important one is non-convulsive status epilepticus.
Meaning seizures without the shaking.
Exactly. It's basically continuous seizure activity in the brain, but it presents primarily as confusion, unresponsiveness, or just being out of it without the typical convulsions. Needs an EEG to diagnose. So yeah, the list is long.
That was an incredibly thorough run-through. Just to recap the structure for everyone listening, we started with stabilization, ABCDE, GCS, then the immediate glucose check. Then we moved through toxins and medications, then focused on the CNS causes, trauma, stroke, infection, followed by common systemic infections, UTI, pneumonia, and finally the metabolic encephalopathies from organ failure, kidney, liver, and that wider net of other causes.
That's the systematic framework.
If you had to leave our listeners with just one core message about approaching AMS, what would it be?
I think the most important thing to remember is that AMS is never the diagnosis itself. It's always just a symptom, often a terrifying one, signaling that something is seriously wrong. The approach we've discussed, that systematic step-by-step investigation, is what allows medical teams to cut through the potential chaos and zero in on the underlying cause.
It forces you to be a detective.
Absolutely. You become a medical detective, piecing together clues from the history, often from others, the physical exam, targeted lab tests, and imaging. You have to connect subtle signs, rule things out methodically, and often make critical decisions quickly. In AMS, having that structured knowledge and applying it systematically can genuinely be the difference between a good outcome and a disaster. Time and knowledge are everything.
And it really underscores how interconnected everything is, how failure in an organ like the liver or kidneys can directly impact something as complex as consciousness and thought.
It really does. It's a stark reminder of how dependent the brain is on the rest of the body functioning correctly. And, if you wanted to dig even deeper, exploring the precise mechanisms, how specific toxins like ammonia or urea actually get past the brain's defenses and disrupt neuronal function, that's a fascinating next level of understanding.